Good evening, everybody, and welcome to our webinar on antibiotics, probiotics, and antibiotic stewardship in the SARS-CoV-2 era. Before we begin this evening, just a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you want to ask questions to our panel, just go on the right-hand side of your computer or laptop and you'll see a question/chat pane, and you can ask your questions in that pane. At the end of the seminar, we're going to be sending you a survey. If you could fill it in and send it back to us, we would appreciate it. And then also 1 or 2 days after the webinar, you will be receiving a certificate of attendance, as well as the recording of this webinar. Again, please go to the right-hand side of your computer or laptop and go to the question chat pane and enter your questions for our panel. We'll be asking or answering questions at the end of the webinar, time permitting. We would like to thank the support of BioK and the Peggy Lillis Foundation, who've made this educational event possible. So without further ado, I would like to pass the floor virtually to Dr. Ellie Goldstein.
Good afternoon and good evening from wherever you are, and thank you for joining us. The COVID-19 pandemic has locked down countries and stressed hospital systems worldwide. Hospitalized patients are receiving empirical antibiotics, and as they get sicker, this empirical therapy is escalated. This creates a dilemma for the hospital antimicrobial stewardship programs, because this additional use of antibiotics can lead to drug toxicities, allergies, prolonged hospital stays, bacterial resistance, and complications such as Clostridium difficile infection. C. difficile infection, or CDI, already accounts for over 500,000 cases a year in the United States, prolongs hospital stay, has a 5.2% attributable mortality, and is costing the medical healthcare system in excess of over $5 billion per year. Now, the use of specific strains of probiotics have shown to effectively reduce antibiotic-associated diarrhea and C. difficile infection in several randomized controlled trials. However, not all probiotics are the same. Our program, next slide, is to raise awareness of these issues, and we try to give some insights into some of the potential solutions with the following presentations that you see on your screen. Next slide, please. Next slide. What we're going to do is start with taxonomy in Lactobacillus species. Now, Lactobacillus was proposed as a genera in 1901, and it was a wasteland for facultatively anaerobic, gram-positive, non-spore-forming rods. Recently, using molecular techniques, they have established that there are at least 261 species in 26 genera, including 23 new species. Now, why is taxonomy and bacterial names important? Well, although it is a broad genus, each named organism has a unique identity, and each strain is genetically distinct and has distinct properties and potential unique health benefits. Not all Lactobacillus strains have probiotic activity, and not all of them work on all diseases. Dr. McFarland, who will be speaking later, published a paper in Frontiers in Medicine in May 2018 called Strain Specificity and Disease Specificity of Probiotics. The probiotics are very frequently used by the American public and are used for therapy and to help the armamentarium of preventing C. difficile. The lactobacillus species, usually in these probiotics, are part of the normal gastrointestinal and vaginal flora, although they may be occasional human pathogens. Next slide. The next slide shows the lactobacillus phylogenetic tree. As you note, there are lactobacilli that are nomadic, environmental, have insect hosts, and a small group in the red on the top left are vertebrate host specific. In humans, these organisms have caused bacteremia, cholecystitis, empyema, endocarditis, meningitis, but are also used for a number of things medically. Next slide, please. The lactobacillus species all produce lactic acid. When you ingest them, they survive the stomach because they are generally resistant to the acid. They have many commercial uses. They're used in milk production. The difference between Edam cheese and Swiss cheese or any other cheese is related to the lactobacillus strain that is chosen. And so they're used in cheese production, flavoring, texture, and ripening. They are part of multiple yogurts, especially those that are live. They are used for sourdough bread and vegetable fermentation. But we'll focus tonight on probiotics to promote intestinal health, especially to prevent antibiotic-associated diarrhea and C. difficile infection. Next slide, please. Now, in these taxonomic change, the column on the left are those that have kept their original names, such as Lactobacillus acidophilus. On the right are the Lactobacillus species that have had name changes, such as what was previously Lactobacillus casei, paracasei, and rhamnosus, which are common organisms used in multiple probiotics. Next slide, please. Now, the lactobacillus susceptibility to different antimicrobials is very variable and difficult to understand. In general, they're resistant to aminoglycosides, fluoroquinolones, and metronidazole. And it raises the issue of if you're taking a probiotic, when do you take the probiotic in relationship to either the antibiotic that you're taking or for the therapy of C. difficile if you're taking it for that as an adjunctive measure. Since they're mostly metronidazole resistant, that this poses very little of a problem. But for anything where there is susceptibility, and I note the paper on the bottom in Clinical Infectious Diseases, where I'm the first author, it will go through these susceptibilities. It is generally thought that you should separate out the probiotic and the antimicrobial you're taking by approximately 2 hours. So this is a practical guide, and you can look up what you can do with the various antibiotics. With that, I would like to have the next slide, and I would introduce the second speaker, which is Dr. Ravina Kular, who is going to talk about the overuse of antibiotics in COVID-19 patients and its relationship to antibiotic stewardship in probiotics. Dr. Kular.
Thank you for that introduction, Dr. Goldstein. On top of the devastation that COVID-19 has already caused, this pandemic could have downstream effects of diminishing antibiotics and also fuel rates of antimicrobial resistance due to the overuse of antibiotics that has occurred during this pandemic. But before I delve into that, let's briefly discuss the background of antibiotic resistance. These are just some of the headlines and news clips that around antibiotic resistance that we have become all too familiar with. This antibiotic resistance crisis is being coined as the antibiotic apocalypse, with us not being too far from that harsh reality of us having no effective antibiotics available to work against bacterial infections. In fact, according to a modeling study that was conducted in 2014, if each one of us does not change our current practice of antibiotic usage, antimicrobial resistant infections will exceed 10 million people per year worldwide. Think about that. That's one person dying every 3 seconds. Next slide. Antimicrobial use is directly correlated to the development of antibiotic resistance. The more antibiotics which are used, the more likely that resistance will develop. This is a very nice graphic here that really shows that. This slide shows the occurrence of penicillin non-susceptible Streptococcus pneumoniae here on the y-axis, plotted against outpatient use of penicillins in 20 industrialized countries. It is a clear representation that shows that relationship of antibiotic usage with the development of penicillin resistance. As antibiotic usage increases, so does the development of resistance. Let's move on to the next slide. Additionally, the more antibiotics that we overuse and inappropriately use, the more likely antimicrobial resistance is going to develop. Globally, up to half of all antibiotic prescriptions in the inpatient setting alone are inappropriate. In the outpatient setting, that is the same case as well. Let's go on to the next slide. Well, let's look at the correlation of antibiotic usage in COVID-19. Where does this phenomena of antibiotic use in patients with COVID come from? Well, in 2008, scientists reviewed a draft of scientific literature from the 1918 Spanish flu, and they also re-examined tissue samples that were stored from autopsies during that outbreak. And they concluded that a vast majority of the possibly 100 million deaths that occurred from 1918 to 1919 was not caused by influenza, but was actually caused due to bacterial poor outcomes. And you can see here in this study that was conducted, in most patients that had influenza, they also had coexisting bacterial infections, with Streptococcus pneumoniae and Staphylococcus aureus being the most common organisms that were isolated in those patients. So some of the concern over the bacterial co-infection in COVID-19 actually stems from the experience from influenza, where bacterial co-infections were quite common and were very well recognized, and were actually pre-existing. There were factors that were associated with a patient going to the ICU. However, experience is growing that the same is not true for COVID-19, which I'm going to delve further into in my following slides. Let's go on to the next slide. Well, anecdotal reports of documented bacterial superinfections show that the incidence seems to be much lower than that in influenza. This first study by Rawson and colleagues reviewed 18 studies and showed that 72% of about 2,000 patients with COVID received antibiotics in the hospital. However, only 8% actually had a bacterial infection or a fungal infection that was isolated. The second study in Italy had about over 16,000 patients who died of COVID-19. And again, super infections were only reported in about 11% of patients. This last study done out of Wuhan, which was the epicenter of COVID-19, where this pandemic started, there were about 190 patients retrospectively evaluated with only about 15% of patients that actually developed a secondary bacterial infections. And the most common antibiotics which were used were your fluoroquinolones, which have a very high risk association with C. diff, which Dr. Johnson will further get into after this presentation. Let's move on to the next slide. This last study by Lansbury and colleagues was conducted a systematic and meta-analysis that of about 30 studies that looked at over 3,000 patients. This was done out of Canada, and overall, only 7% of patients that were hospitalized with COVID-19 actually had a bacterial co-infection. And there were a higher percentage of patients that were actually in the ICU that ended up developing a bacterial infection. And the most common bacteria which those patients had isolated are listed on this slide. So for the purposes of antibiotic stewardship, COVID-19 is not very similar to influenza, where there was a higher percentage of patients that did develop a bacterial co-infection. Most patients with COVID-19 present to the ICU, and they likely have a viral pneumonitis, or they have, rather than having bacterial co-infection. Let's move on to the next slide. Well, is there any evidence that shows that early usage of antibiotics is actually beneficial in patients with COVID-19? Well, this study very nicely answers that question. This was a retrospective study that was conducted in ICU patients with COVID-19, and it showed that there was no difference in mortality in those patients that received antibiotics early on versus no antibiotics, with a mortality rate about the same of about 25%. Let's move on to the next slide. Well, where does the World Health Organization stand in regards to antibiotic usage? We do know that the WHO has had a very firm stance on acknowledging that antibiotic resistance is a public health crisis. They actually updated their guidance where they've stated that antibiotic usage in patients with COVID, which have moderate symptoms and are have moderate severity, should not get antibiotics. Only those patients which are severely sick with COVID-19, you should consider antibiotics in. Let's go on to the next slide. So what you need to do as a clinician is determine, first of all, whether a patient has a bacterial pneumonitis or a viral pneumonitis. And the World Health Organization has put together a very nice schematic here where to have a clinician suspect whether antibiotics are necessary or not. You can see here on the right-hand side, bacterial pneumonitis, which would require someone to potentially have antibiotics, a patient be put on antibiotics, should be thought about if there's a acute onset, if they have a higher temperature, and if they have a unilateral positive lung findings as well. Let's move on to the next slide. Well, since there is no vaccine that's available and there is no treatment that's available, we know that preventing COVID-19 through infection prevention is key. And what I mean by that is that we have to utilize our infection prevention tactics, such as avoiding contact with those infected individuals and reinforcing our immune system. And we need to also put on those masks, physically distance ourselves, and also embody hand hygiene, good hand hygiene. Large clinical studies from China have indicated that GI symptoms are common in patients that present with COVID-19, and this may actually be associated with disease severity. Probiotics have been shown to prevent and or decrease the duration of bacterial and viral infections, and I don't want to steal Dr. McFarland's thunder here, but she's going to really delve into those, where the studies stand in terms of probiotic usage and COVID-19, as well as other infections. Last slide. So in summary, antibiotic resistance is a serious global threat. Patients with COVID-19 are receiving a very high rate of inappropriate antibiotic usage. It's really important at this time and age where we have diminishing development of antibiotics to really preserve our antibiotics that we have and to only utilize them when it's most appropriate or when it's the most stewardly too. Studies evaluating the usage of probiotics in patients with COVID is important in the future. So let's go on to our next slide, where I will present our next speaker, Dr. Johnson, who will be speaking about C. diff, which is another bad consequence of antibiotic usage and the second wave post-COVID-19.
Thank you, Ravina. Can we go to the next slide? So the second wave has been discussed widely in relationship to COVID-19 pandemic. Here are a few excerpts from the media. One, why the second wave of the 1918 Spanish flu was so deadly. The first strain of the Spanish flu wasn't particularly deadly, then it came back with the full vengeance. China races to contain a second wave of coronavirus cases in Beijing. This was in mid-June. And then also, is the second wave of COVID in the US, or are we still in the first? We've got a big puddle there. Next slide. So can we expect a second wave of C. diff after the COVID-19 pandemic? Data suggests seasonality for C. difficile infection, or CDI. Seasonal peaks usually follow viral respiratory infections such as influenza and RSV with a lag time. There is correlation with respiratory infections and antibiotics given during the time period. Antibacterial antibiotics are frequently given to patients with SARS-CoV-2 infection, just as Ravina had mentioned. And diarrhea is often a symptom of COVID-19, just to make things a little more confusing. In one study, 19% of patients with low severity COVID had diarrhea as first symptom. Next slide. This first study that I want to review regarding seasonality and C. diff looked at hospitalizations for both CDI and influenza between 1998 and 2005. These are data from the National Inpatient Sample from HCUP, the Agency for Healthcare Research and Quality. In this study, CDI incidence was modeled as an autoregression about a linear trend, and the association of influenza with CDI was calculated with cross-correlation functions and filtered to remove temporal patterns. The results showed monthly cases of CDI showing a positive linear trend with a clear pattern of seasonal variation. Influenza activity preceded CDI activity on a national and regional basis, and the average burden of seasonal, i.e. winter CDI was 23%. Next slide. This is a figure from the paper showing the peaks of influenza on top and the incidence of CDI on the bottom slide. And maybe a little bit hard to show here, but the peaks of CDI did lag with the peaks of influenza. Next. The second study I want to review talked about seasonal variations of CDI in Quebec, Canada, from January 2005 to December 2008. And seasonal variations in CDI with a higher incidence during winter has been reported, as I just mentioned. And their hypothesis was that the association was due to increased antibiotic use for respiratory infections during this time period. What did they find? CDI incidence followed a temporal variations of both influenza, RSV, macrolide prescription with a delay of approximately 1 month, and fluoroquinolone prescription with a delay of approximately 2 months. influenza virus and RSV were independently associated with CDI. So not just the antibiotics, but the viral infections themselves. Next slide. This is a figure from that paper showing in the gray line at the top the incidence of CDI in both the top and bottom figure. And the top figure shows the incidence of influenza and RSV overlaid on the CDI trend. And on the bottom slide shows prescriptions for fluoroquinolones and macrolides in association with the C. diff peak. And I just highlighted in the red arrows on the top the peaks for CDI and showing this lag between influenza and RSV and C. diff. Next slide. This third study looked at CDI seasonality patterns across hemispheres and continents. This was a systemic review, included 13 publications from North America, 5 from Europe, and 2 from Oceania. And the monthly frequency of CDI here was extracted, standardized, and weighted, and cross-correlation coefficients were calculated to determine the correlation and lag between the year-month frequencies across hemispheres and continents. And their results showed similar seasonal CDI patterns in North and South hemispheres, with a peak in spring and a lag of 8 months between the hemispheres. There was no difference in patterns across Europe and North America countries. Next slide. So what about co-infection with CDI and COVID-19? Well, this is already reported. This is a early publication from Detroit, where they documented 9 cases of co-infection with SARS-CoV-2 and C. diff. 3 of these patients had prior CDI episodes. 2 had diarrhea and were positive for CDI on admission, and 7 developed CDI after the COVID diagnosis, with a mean lag in diagnosis of 6 days. All had received antibiotics, with a mean duration prior to CDI of 5 days. 4 patients died and 1 patient was discharged to hospice. The underlying characteristics of these patients are shown here. The median age was 75. 78% were women at the mean Atlas score of 6. 4 patients required ICU and vasopressors, and the mean ferritin level was quite high, 1,459. The mean white count was 12, was also elevated, and the mean creatinine was quite elevated, 4.2. 3 of these patients, however, were on hemodialysis. Next slide. So in summary, CDI infection is seasonal and follows respiratory infection peaks with a 1 to 2 month lag. There's a correlation with influenza virus and RSV, and there's correlation with antibiotics given during respiratory infection periods. Co-infection of CDI and COVID-19 has been documented already, and expect to see an increase in CDI cases if you've had a significant number of COVID-19 cases. Thank you. Next slide. Next, I'd like to introduce Dr. Lynn McFarland, who will be talking about probiotics in the COVID era.
As you've just heard, the increased use of antibiotics in COVID patients may result in increased numbers of antibiotic-associated diarrhea and Clostridium difficile disease. It's been suggested that probiotics might help. So today, I'd like to update you on what we now know about the proper use of probiotics and how to choose the right probiotic for the right use. Next. Next slide, please. However, choosing the right probiotic can be difficult. There are many different types of challenges involved with this. The first one is that, as most of you are aware, if you go into a pharmacy or your Safeway store, or you go online, you are assaulted by a wide diversity of different types of probiotics. There's over 260 different types of probiotic products on the market globally, so it makes the choice of choosing the correct one more difficult. Another challenge is that regulations differ by country. In Europe and in other countries, they are prescriptions used as a prescription drug and regulated like most prescription drugs. In some, they are treated as over-the-counter medications with less regulations. And in the United States, most of the probiotics are sold as dietary supplements, which are less regulated by the FDA. And another challenge is that the literature is often confusing. Sometimes you have studies that show positive effectiveness of probiotics, and then the next day it seems a new story comes out that says no, probiotics are not effective. And so it's difficult for the public to try to squeeze out the idea of which probiotics are effective. Another challenge is that the quality varies. Not all these products on the market are equal in quality. Studies have looked at commercial probiotics on the market and determined about a third of them do not contain what they say on the label. And so the manufacturing is not as tightly regulated as it is in other countries. So unlike other medications, when you just go to the pharmacy and pick one up, you need to consider who manufactures the probiotic product that you're considering on taking. You want a well-established manufacturer that has good clinical practices and good manufacturing practices, good quality control. So this is an unusual kind of consideration that the general public doesn't usually have to deal with. The general public right now considers the common perception is that all probiotics are the same. Well, this just isn't true. Newer research has found that there's a vast difference between the efficacy of probiotics. Another challenge, next slide, is that there's the probiotics have been used to see if they're effective in a wide variety of different types of diseases. If we looked at the literature from 893 randomized controlled trials spanning 59 different types of disease indications, we find that there's a wide variety. The diseases can be in the GI tract, they can be in the bloodstream, dental infections, they're being tested for obesity. All these different types of disease indications reflect the interest that there is on probiotics. People want to know where they best work. So today we're going to focus on two of these indications. The first is the prevention of antibiotic-associated diarrhea. 17% of nearly 900 randomized controlled trials have been focused on this disease indication. And we're also going to look at C. difficile. So these are the two major side effects of antibiotic use in the COVID patients. Next question. Sorry, yes. So the problem is, how do you know which probiotic is the best for you? How do you recommend the right probiotic to your patient? So I'm going to show you three sources of information that you can gather. This first one is a practical guide that was published by Sniffen in 2018 in an open access publication. So anybody can have access to this publication and download it and get the information. What they did was to look at 249 randomized controlled trials that used probiotics, and they looked at only the 29 top probiotics. They only looked at probiotics that had at least 2 randomized controlled trials per type, per disease, and then tried to look at the evidence to see, did they find significant efficacy or not. They separated out into those that had strong evidence and those that were not effective. So this is a very simple kind of a surface look at whether or not a probiotic is effective, but it's quite understandable for the general public. So if you look at the first disease allergy, we see for the prevention of allergies, none of the probiotics examined had strong evidence. And yet a lactobacillus GG had only 3 studies. 1 was positive and 2 was negative. So the net was 1 negative. And so it was considered to be not effective. If you look at the prevention of antibiotic-associated diarrhea, you see that Saccharomyces boulardii has a lot of studies, 18 positive and 9 negative. And 2 different types of probiotics that contain lactobacillus. One, BioK, has 3 different strains, though it has 3 positive studies and 1 negative, and so it was considered to have strong evidence. And then Lactobacillus casei, another different strain, has 2, so not quite the weight of all the number of studies, but still a net of 2. So those are considered 3 probiotics you can go into the store and buy to prevent antibiotic-associated diarrhea. Now, in contrast, when you look at the studies that were the types of probiotics that were not effective, we're looking at the same lactobacillus strains. And if you see the ones in red, this shows the strain specificity and disease specificity of Lactobacillus rhamnosus GG. It's a very popular type of probiotic. It's been well used and well researched, but it's just because it's effective in one disease indication. This shows that it's not effective in all different types of diseases. So this shows disease specificity. When we look at the probiotics that are used for treatment, the treatment of acute pediatric diarrhea, we see that Lactobacillus GG is highly effective in this disease indication. So this slide shows that that probiotics are not all equal. They're different by the type of disease you want to prescribe them or use them for. And there's a difference in strains that you actually have to match up with the disease. So it's a little challenging, but if the patient can go in to where they want to buy their probiotic with these kinds of tables, they can be very useful guides for the general public to enable them to choose a proper probiotic for them. Next slide. The second source of information is meta-analyses. This is a statistical tool that allows you to take a great number of studies and blend them together and come up with a pooled estimate of how effective they are. However, many meta-analyses out in the literature pull together all the different probiotics and just report the global, yes, probiotics are effective for this, or they're not. Now we know that because of strain specificity, that's not appropriate. So what you need to do when you're going through the literature is to look at meta-analyses and see if they have separated out the types of probiotics and only analyze them in the subgroups that have the same type of probiotic. So this figure shows that there are 6 different types of probiotics that were used in a meta-analysis for the prevention of adult antibiotic-associated diarrhea. There were 22 general randomized controlled trials, but they didn't pull together all the trials and report one result. Rather, they did subgroups of specific types of the probiotic types. Lactobacillus casei was effective, and here we find the second subgroup was Lactobacillus GG. That was not effective for the prevention of adult AAD. Interestingly, if you have pediatric studies, Lactobacillus GG is effective to prevent pediatric AAD, but not adult. So there's a difference in your host also. Lactobacillus reuteri was found to be effective. They found another strain that was effective for the prevention, and a 2 strain was not effective, and then a 3 strain mix BioK was effective. So you can go also to the store with this meta-analysis and pick out which strain is more effective if you want to prevent adult AAD. And this is a side effect we'll see in COVID patients that are getting antibiotics. Next slide. So the third source is interesting. It's like, well, what happens when randomized control trials are great? They're very regulated. You have a very defined population. But what happens when you take probiotics and you use them in real life? So here, there's been several studies that have looked at what happens when you give probiotics to any patient that comes into your hospital and is receiving antibiotics. What happens if you give them probiotics? Do you find a decrease or increase or no change in the hospital-wide rate of Clostridium difficile? This is one study that was done from California. The interesting thing is that they have an acute care hospital and an affiliated long-term care facility. So the data here is given, the bottom part of these columns is the C. difficile rates from the acute care hospital, and the top part is from the long-term care facility. And as you can see, in 2008, they were doing fine, but by the time they reached the end of 2008, they were having an outbreak of Clostridium difficile, and it was continuing to increase in January. So they said, okay, we have to do something. So they started giving every inpatient that was receiving antibiotics 2 probiotics, the Fluorostor, which is Saccharomyces boulardii, a yeast probiotic, and Lactinex, which is a mixture of 2 different types of lactobacillus strains. They gave that to every patient that was receiving antibiotics. And that, as you see, a dramatic decrease in the Clostridium difficile rates, not only for the acute care hospital, but in their long-term care facility. Now, and then to an effort to really severely decrease C. difficile rates, they also started an antibiotic stewardship program that was started here. And then they also said, let's try to decrease PPI use, and they started that here. And as you see, this decrease continued. So with these 3 different measures that they gave to patients, we found a 75% reduction in Clostridium difficile rates, which is great. But then they said, well, let's try and see if we use a different type of probiotic and see if we can even further reduce this. So they substituted the Fluorostor and the Lactinex with BioK+, which has 3 strains of lactobacillus, of Lactobacillus acidophilus, CL1285, and then 2 strains of what used to be Lactobacillus, but Dr. Goldstein has shown there's a change in taxonomy. So it's now Lactocasei Bacillus casei 80R, and then Lactobacillus casei, Lactocasei Bacillus rhamnosus, CLR2. So a mouthful. But basically, let's give this combination of 3 lactobacillus strains and to every patient who's getting antibiotics and see what happens. And as you see, there's a very dramatic decrease in Clostridium difficile rates in the acute care hospital, and also in the long-term care facility. They actually continued giving the BioK probiotic for years afterwards, and they were able to knock down the C. difficile rate to practically 0. So this study confirms that there's similar hospital-wide probiotic use studies that are out there in the literature where they just give it to every patient that comes in with antibiotics and then monitor the Clostridium difficile rates. They find that depending on which probiotic you use, you can see a reduction in C. difficile rates. They don't see this with every probiotic that has been tested. So again, we have to remember it's important to choose the right probiotic strain or mixture. Next slide, please. So recently, just this year, the new 2020 American Gastroenterology Association guidelines have come out for the prevention of C. difficile infections. And for the first time, they have recognized that probiotics are strain specific. And so instead of just having a global conclusion that probiotics are good or are not effective for Clostridium difficile infections, they now recommend 4 of these different 4 probiotics for the prevention of C. difficile infections. The first one is Saccharomyces boulardii. This is based on 9 randomized controlled trials. And the second is what they call a 2-strain combination of Lactobacillus acidophilus and Lactobacillus casei. This is how it was reported in the original studies. This is based on 3 randomized controlled trials. And again, more refined identification assays have determined that there is now and always have been a 3rd strain. So it's actually not a 2-strain combination, it's a 3-strain combination called BioK+. So those 2 are based on multiple randomized controlled trials and have the backing of the American Gastroenterology Association. They also recommend a 3-strain combination and a 4-strain combination with combining Lactobacillus and Bifidobacterium. But interestingly, that's only based on 1 randomized controlled trials. There's no secondary confirmatory trials for these 2 probiotics. So I would urge caution when you're trying to recommend those mixtures. Next slide. In summary, The probiotics in the COVID era, how can we best use them? Are they useful? We know that hospitalized COVID patients receive more antibiotics, some with reason, some inappropriate. With more antibiotic use, we're going to see higher rates of antibiotic-associated diarrhea and Clostridium difficile disease. We know that AAD leads to premature discontinuation of antibiotics, especially by outpatients. If you start developing diarrhea, a lot of people stop taking the antibiotic, which doesn't cure your initial infection, which is not good. The more C. difficile rates we see, the higher burden on an already stressed healthcare system, which is something we don't need at this time. So the use of probiotics can lead to less AED and C. difficile rates if we pick the right probiotics. It saves money for our healthcare system, lessens the length of stay in hospital patients by 3 to 5 days if they have C. diff, and can increase compliance to the antibiotic being taken. However, we want to recognize that probiotics should not be considered in isolation. They need to be combined with a good antibiotic stewardship protocol, good infection control practices in order to be a very effective bundle. So I think there's a role in probiotics in our COVID era, but it has to be used with other infection control procedures. Thank you.
So let's bring our panelists back for a question period. Again, please go to the side of your right-hand side of your computer, and you can type in your questions in the question-chat pane. So we have several questions here from the audience. Have you ever used PCT to determine bacterial co-infection following viral infection or stewardship protocols purposes? Who would like to take the question?
What bacterial what?
So this member of the audience would like to ask if this panel have ever used PCT to determine bacterial co-infection following viral infections or stewardship protocols purposes.
I think that's a typo and they mean PCR because the T and the R are next to each other.
Yeah, they might mean, I think, procalcitonin, maybe PCT
okay.
procalcitonin.
Go ahead, Ravina.
I mean, I was going to say, most of the literature there, it comes out of, Dave Gilbert is from Providence Hospital, and he has shown there that procalcitonin has been beneficial in determining whether the patient has a viral infection or bacterial infection, and even determining whether antibiotics therefore are needed or not. So, I was at Portland for some time managing antimicrobial stewardship, and procalcitonin levels were used there to help with antimicrobial stewardship. Maybe Ellie or
I would say that I think that procalcitonins are best used with pneumonias for help. They're not end all and be all. They don't work all that well in sepsis. American procalcitonin measurements are different than European, and many of the studies are European. But it's not just a positive or negative. They also use a 90% reduction rate of procalcitonin in order to end antimicrobial therapy when it's no longer needed. So it can be a good adjunctive measure.
Another question, is there a correlation between length of time for antibiotic treatment and C. diff?
Stu?
Yes, the correlation between the end of antibiotic treatment and C. diff?
Length.
The length, yes. There is some data to suggest that the longer you're on antibiotics and the more antibiotics, your risk is increased. But this clearly can happen with one antibiotic and can happen fairly soon after initiating the antibiotic. Clindamycin is probably one of the most notorious drugs that has been associated with C. diff historically.
Next question, recommended resources are great, but still very confusing. How do we recommend this to our patients? Will they know what to look for in the stores or online?
That's a great question. I think the problem is that we have so much research on probiotics and randomized controlled trials. It's really difficult to try to condense this all into one practical guide. What we need is and the people, there are different people, the different experts disagree, and so we all it's tough to come up with a consensus. And then as soon as we come up with a consensus, new randomized controlled trials come up, and that changes. So what I was suggesting for the best thing for the general public and for physicians who aren't keeping up with the literature is to use Dr. Sniffin's practical guide, where they can take that from the web. It's easily accessible. They can download the paper. In it are two tables. One, it gives you brand names, and so and the strains that are in those brand names, so it's easier to shop. And then the other, there's two tables that look at whether or not which strains you should use for which type of disease that you want to treat. So if you can find a good practical guide, this is really nice. A lot of the scientific meta-analyses make sense to scientists, but not to the general public. And so it's difficult to recommend using the best type of scientific evidence we have. I think more good practical guidelines have to be written for each disease, and that's what makes it difficult. American Gastroenterology Association writes guidelines for C. diff, but they don't give one for antibiotic-associated diarrhea or necrotizing enterocolitis. So each disease needs its own recommendations. So look for a practical guide. I think that's the best way. We need to develop a good phone app that you could take the phone app with you to your grocery store and go, okay, I'm going to copy the name of this one and I'm going to match it with this. This is what I'm going to use it for. Is that a good match? But we're not quite there yet.
We should probably caution physicians to tell their patients that sources like going in and asking the stock boy which the best probiotic is or what sells most is probably not a good idea. And because the packaging looks nice, that may not necessarily be the best probiotic. But look at what there are randomized controlled trials for, and that there is some data, and then decide from there.
Yeah, I think the biggest challenge for when the general public goes to the shelf with probiotics on it is because they're dietary supplements, they have structure function claims. So they say they enhance the immune response or they strengthen your GI tract. Those aren't really very specific kind of recommendations. And so it doesn't say, well, I'm having antibiotic-associated diarrhea. Is that what I need for? And it's more a reflection of how dietary supplements are regulated. If you go to Europe and you look at what the product says, it says specifically this is good for the prevent antibiotic-associated diarrhea, but they're regulated as more of a medication in that country. So it's more not a reflection of the level of science, but the reflection of what our current regulation is.
Another question, can you use probiotics in people that are immunosuppressed, for example, on a biologic to treat IBD or rheumatoid arthritis?
There are studies that are looking at these things at the moment, but not entirely published. You do have to be careful that most studies do exclude immunocompromised hosts that are neutropenic, and there are reports of lactobacillus bacteremia with some products more than others. I think lactobacillus GG has more bacteremias reported, but that may be a function of it being very popular in Europe where these cases are reported. The other studies for ulcerative colitis and rheumatoid arthritis, you'd have to really look and see what's published, but people are studying these things.
Maybe one for Dr. Johnson, since most severe COVID patients are in isolation units under more rigorous infection control practices, wouldn't that prevent spread of CDI?
Yeah, potentially. I would say
Oh,
Uh-oh.
I think we haven't lost Dr. Johnson for a second there. So perhaps a question while we wait for Dr. Johnson, for Dr. Goldstein. If I want to use probiotics to prevent CDI and the probiotic contains a strain that is sensitive to the patient's antibiotic, how long, hours in between dose of antibiotic and probiotic, do I stagger the dose?
The data, there's a gentleman named Maziad in Quebec who gives it to all his patients in a hospital with good results. And I think he uses a 2-hour separation from the antibiotic to the probiotic. So 2 hours seems like a reasonable amount to get through the system.
One question for Dr. Kullar. Since COVID plus patients, mild to moderate symptoms, are suggested to self-quarantine at home, do we see increased antibiotic use in outpatients? Patients may email their physicians wanting antibiotics to prevent possible infections just in case.
Yeah, I think that's a great question. I think whether it's a COVID pandemic that we're in or not in a COVID pandemic, that's quite common. That commonly happens where a patient may call their healthcare provider and ask for antibiotics. And I think that makes it even more important for us clinicians to be the educators and to fight for appropriate antibiotic usage and just let them know that COVID-19, remind them, is a viral infection and antibiotics do not treat viral infections, and antibiotics are not appropriate right now, and even just in case, not appropriate. So there again, the education should come about for the consequences of inappropriate antibiotic usage, which is C. diff, spore-forming diarrhea, which could linger on and is highly transmissible.
I think Dr. Johnson has joined us again. So did you want to finish that answer?
I'm not sure I heard the question. Somehow the internet goblins kind of took me off.
Okay, since most severe COVID patients are in isolation units under more rigorous infection control practices, wouldn't that prevent spread of CDI?
It's very difficult to completely eliminate horizontal transmission in any setting because this is a low inoculum pathogen, meaning that the very, very few number of spores are only necessary to cause infection. So you can achieve some degree of decreased transmission with horizontal infection control measures, but no one's been able to completely eliminate that. So I think additional measures such as appropriate probiotics can be very helpful.
Another question, what is the panel's take on the US probioticsguide.com or probioticchart.ca annual updates, renowned experts involved? There is a phone app as well.
Yeah, so I've looked at some of I think these are initial attempts at trying to put up an online web internet source for probiotics, which is a great idea, and also looked at some of the probiotic phone apps, and at least the initial ones have been a little misguided. They're not quite as rigorous as recommending probiotics. If there's one positive study, then they go ahead and say, yes, that's great. So, but there's not, at least have 2 randomized control trials that show that there's an effect. So some of them have not been as rigorous as they need to be. We need a good body of people to, there's a probiotic international group to sit down and do a consensus and do a good one. I think we're headed in the right direction, but we're not quite there yet.
With Biocare and other probiotics being used more widely by hospitals, have any cases of bacteremia been reported?
So, as I mentioned in my lactobacillus paper in Clinical Infectious Diseases, which is open and able to be used freely. We do review the reports. Most of them are with Lactobacillus GG and come out of Scandinavia, where that product is used extensively. Maziad in Quebec that used BioK looked for about 5 years, and there were no cases, and he gave it to every patient in his hospital, and there were no cases of Lactobacillus bacteremia in the patients of BioK use. So there may be other studies, but in general, it is possible, it is uncommon.
Is there any data relating to the use of probiotics for AAD or CDAD and reduced costs of patient care?
Yes, there are 2 or 3 studies that have looked at the cost effectiveness of probiotics for C. difficile, and they use cost modeling, and it shows that if you use an appropriate probiotic, you can save anywhere from $2,000 to $5,000 per patient per episode. So you do see significant reduction, at least for C. difficile. For AAD, it's kind of, I don't think I remember any that have actually focused on AAD. But again, that's sort of a harder thing to nail down because it's more of a general disease side effect and not quite as documented as other Clostridium difficile diseases. But Ellie, Stu,
I would reference our paper that we wrote. We all wrote a paper on the use of probiotics in ASP bundle, and in that paper we do reference some cost modeling studies that have been conducted for probiotic usage, and at least for CDI.
In this age of pandemic, is there an indication for us to have all of our patients on probiotics prophylactically?
No. So
I would go ahead.
Ellie, go ahead.
No, go ahead, Lynn.
So this is another concept that I continually run into when I'm talking to the general public is like, well, should I be taking probiotics every day like a vitamin? It's sold like a vitamin, like a dietary supplement, shouldn't I? And you want to strengthen your immune system and do good. You have to recognize that really the chief advantage, the chief scenario when to best use a probiotic is when your normal flora, your normal microbiome has been disrupted, either by antibiotic use or by travel or by stress or a chronic GI disease. That opens up the fact that your normal flora, which is a very profound protective environment and that has lots of capabilities to fight off pathogens, has been disrupted and is no longer functioning as well. Probiotics come in, they're living organisms, they have multiple types of mechanisms of action that they can fight against, but I think the most important effect is that they help the normal flora restore itself. And so you have what is normally good for you and beneficial and protective for you. When you don't have a disruption, we've done many studies, early studies on this. When you give probiotics to a normal, healthy adult or child, and you try to see, is there an effect? There's absolutely no effect. The probiotic gets washed out with the rest of it. It doesn't there's no open attachment sites that they don't attach to it. So there's no real benefit to taking a probiotic every day. You only should use it when you need it. And then when you don't need it anymore, you can say, okay, I don't need to take probiotics. Recognizing that it could be up to 6 weeks for your normal flora to come back. So you might want to take probiotics once you have a disruption for a longer period of time. But should you be taking it before the event? That's like carrying around an open umbrella in case it rains. You don't, in Seattle, yeah, maybe. But you don't really need the umbrella until the clouds actually come in. So no. Ellie and Stu and
I would agree.
No. I would say that really the best use is for people who are going to get antibiotics to start it early with the antibiotic and continue it afterwards to prevent the development of antibiotic-associated diarrhea, C. difficile. How long after? As Lynn said, maybe up to 6 weeks. Most studies only go about 9 days, but you know, this data is evolving. So to be used while patients are receiving antimicrobial agents.
Another question, not all hospitals with large numbers of COVID-19 cases have seen an increase in C. diff cases. Is there any speculation why?
That's an interesting question. I think that most hospitals have really kind of switched over, have decreased their other census, if you will. At least our hospitals in the Chicago area have seen this, so, and they've stopped elective surgeries and other things. So I think the patient population in hospitals are a bit different now. So this increased antibiotic use in patients with COVID, mostly inappropriate antibiotic use, is kind of balanced by the general census of the hospital is down. And I think that may be one reason why it's not seen everywhere, but I don't know. It's a good question.
Another question, is there any data available regarding the effect of COVID-19 on intestinal microbiota?
I'm not familiar with any data on, but definitely good to study.
Has there been any data on CDI and correlation of worse outcomes in patients with COVID-19?
The only data that I've seen is that one paper that I presented from the Detroit hospital. And these patients were quite sick. There were several patients that died. It wasn't clear that it was necessarily due to C. diff, but you know, I think the underlying status of many of these patients were severely ill from complications of COVID.
In the Quebec study, C. diff incidence not only correlated with antibiotics given during the winter respiratory season, but also independently correlated with influenza and RSV infections alone. What is the proposed mechanism?
Yeah, so the authors of the paper did some speculation on this, and it is just speculation, but the thinking was that that may be related to close sequestering of individuals, maybe changes in diets and activity, hospital overcrowding, such, but it's still speculative, but it does seem to correlate. And there's also been association with norovirus and C. diff as well. And it may be that these sequestering and lack of less outdoor activity may predispose to both those conditions.
There was a paper presented at Infectious Disease Society about 2 years ago. I think you were in the audience, where they looked at people with cholera, and they found that they were more likely to become colonized with C. difficile, not necessarily infected, and that they had more than one thing going on. But the primary indication was the primary, like cholera, and then they became more readily colonized because their intestinal flora was disrupted with C. difficile. So it depends what test you use, whether you're just using a PCR or you're using a toxin assay to tell you that they have disease or there's colonization.
That's true. We do live in an era of very sensitive testing for C. diff. So not all C. diff is responsible for the symptoms that are presented in this particular patient.
And another thing we have to recognize is that we are living at a very unique time. The COVID pandemic is still relatively new. Data is still being collected, and so like the impact of coronavirus on the normal microbial ecology is, I'm sure there are people out there studying it, but it takes time to do the studies and to get it published. And so we don't know everything about COVID yet. We're still on the developing forefront of some of the research, and some of these results will come as time progresses. But we live in a very unique time. We have the pandemic that is unfolding in front of us. We have access to data thanks to the internet. so many people are working on these various problems. So we have an unprecedented time of researchers really focused on this specific disease. So some of these answers are going to just have to wait until we have the data in and the research has been done. But it's unprecedented and a really unique time. So sorry.
And one last question, are there probiotics that prevent ventilator-associated pneumonia?
Yeah, so one question that was brought to me was that how should we use probiotics? We know that most of them aren't very good to prevent respiratory tract infections. So I went back and I looked at the type of studies that were done with that. Most of those were done in pediatric to prevent colds. Most of the probiotics some of them were effective, some of them weren't. Lactobacillus GG was very good for preventing colds in children. But most of the deaths that are being done in COVID patients are ventilator-associated bacterial pneumonia. And so I said, well, let's go back. Are there any studies with probiotics? And this outcome was very small and kind of focused outcome. I did find that 10 different probiotics did have randomized controlled trials, only 14 randomized controlled trials. Most of them just had one trial that didn't work with their specific strain. 2 of them had more than 2 randomized controlled trials. Lactobacillus planarium 299V was not significantly good for ventilator-associated pneumonia, but a 4-strain mixture called Symbiotic 2000 was highly significantly protective in ventilator-associated pneumonia. So that might be one type of probiotic that you could give prophylactically to your patients that are in ICUs and to see if you could prevent this. But there's only 1, 2, 3, 4, there's only 4 studies. So it shows some initial interest in it and some a hint that might be one probiotic, but it's one probiotic different from all the rest of them that have been used. So our normal standard go-to probiotic strains haven't been tested for ventilator-associated pneumonia, but there are some strains that might be effective. So I'd like to see more studies.
Well, I'd like to thank all of our panelists for this very enlightening presentation in this unique era that we are living through, both healthcare professionals and patients alike. Remember, you will be receiving a recording of this session so that you can listen to it again attentively. And if you if you do not get it, you can go on the rbcconsultants.com website, and under the event tab, the recording will be there. So again, thank you all for joining us this evening. We hope you've enjoyed the presentations. Good night, everyone.
Good night.
Good night.
Night.
Bye.